Well, we're ready to start again the afternoon. And we've got many well-known speakers today. We're going to be talking diagnosis, treatment, and controversies. And with this, hopefully there'll be a lot of good information, as has been disseminated so far through the meeting, as well as a lot of new things that many of you may not have already heard about. First, I want to run through some of the things that all of us have listened to and heard about and talked among ourselves in groups. We're just going to run through a few quick slides of questions. Last night, the fundraiser was Arsenio Hall's hat, and unfortunately, it was unable to bid high enough. But these are the slides that make you go, This is Lyme. It says, "Bummer of the birth map, Mark Howe." Okay. So, if Lyme disease is characterized by a bite of a tick, Ixodes damoni, but this tick is actually Ixodes scapularis, does that mean that Lyme disease does not exist? If Lyme disease is characterized by a rash, erythema migraine, subsequent to an insect bite associated with the flu-like illness, and if the rash is not observed by a physician, does that mean that Lyme disease cannot be a diagnostic option? If Lyme disease is diagnosed in late stage by characteristics of a systemic illness with positive laboratory confirmation, do all patients with negative Lyme titers not have Lyme disease? Before we knew about hepatitis C and others, if you had jaundice and had abnormal liver profile, but the tests for hepatitis A and B were negative, you were diagnosed with non-A, non-B. Why do we not have a non-Lyme Lyme titer? If the basis of Lyme disease is going to be whether there is a positive titer, and if the published is an article stating that nearly all the lab tested were inaccurate in the laboratory diagnosis of Lyme, then whose tests are correct? If research physicians can review the charts of numerous patients that clinically have Lyme and have responded to appropriate antibiotic therapy but have negative Lyme titers, can they say that they do not have Lyme? If a test for a disease process does not exist, then does the disease not exist and therefore not to be treated? The example I always use is if we've never had mammograms and you had a lump in the breast, does that mean breast cancer doesn't exist? Why is it acceptable for patients to be given the diagnosis of seronegative rheumatoid arthritis and be treated with very toxic drugs such as prednisone, methotrexate, and others, but when individuals contract Lyme disease, they can't be treated with drugs that are essentially non-toxic? We'll get a little bit more wordy. Okay, if patients need only be treated for a conventional 2 to 3 week therapy for Lyme disease, and all the symptoms that after that time are autoimmune syndrome, then why can Borrelia burgdorferi be isolated by culture in patients after they've completed conventional therapy when symptoms return and even when symptoms don't return? This is one little pet peeve. If TB has doubling time of about 12 hours and is treated for 6 to 12 months, and Lyme doubles 3 to 12 hours, then why is it only treated for 2 to 3 weeks? Ain't got kids, this is a good one. Why can dermatologists treat acne for months and years with antibiotics, but individuals with Lyme disease should only receive 2 to 3 weeks of antibiotics? And I hate to say it from a personal standpoint, I've got a baby who'll be 1 this month who's been on antibiotics for 10 months for his sinus and ear infections, and a 3-year-old who's probably been on antibiotics for 2.5 of his years, and no one says a thing. If post-Lyme syndrome is an autoimmune phenomenon, then why does it respond to antibiotics? Okay, here we go. If you perform a study on patients that is so limiting due to the restrictions of the presenting characteristics as to eliminate most all patients with the studied disease, does that mean you have a true profile of the actual patients with the studied disease? And does that mean that the treatment that worked for that restricted group will work for all patients with that disease? Make sense? You guys, sugar hasn't kicked in yet. Okay, in other words, if you eliminate such a, in other words, if you don't have a 5-centimeter rash and you don't have a tick bite and you don't have all that, and you take all those people that do and you treat them and they know they get better, what about everyone else who doesn't have those symptoms? initial presentation of the new disease process in a group of patients, is that the only presentation that one can have for that diagnosis, or is the development of the disease characteristics an ongoing process that stops only when the disease is finally and totally described, and who is it to say that it's time to quit adding symptoms and characteristics to the diagnosis? And finally, this is what I see in the office all the time. It's serious, isn't it? You can't find anything wrong with me. Okay, at this point, I'd like to introduce our next speaker, Dr. Joe Borascano. I've known him for a number of years. He and I have talked on the phone, and we've faxed things back and forth. I somewhat refer to him as the guru of treatment. He has published a number of papers, certainly is in the height of the controversy, along with Dr. Paul Lavoie, who was out at the CDC meeting, so he knows exactly what's going on, not only locally and nationally. And everything he'll tell you is going to be interesting, I'll guarantee. Dr. Joe Borascano.
Good morning, or I should say afternoon. You can tell I had my sugar for lunch. My topic today is gestational Lyme borreliosis. I wanted to use this topic for two reasons. First of all, because it's never been presented at a national forum before, believe it or not. Louder? Okay. In the back, this is so loud, I hate to do it. I was saying that I want to present this topic because it was never presented before in a national forum, and also because I wanted to present a case that was very disturbing and points out many of the things that we've talked about at this conference today and yesterday in terms of difficulties with diagnosis and certainly difficulties with treatment, implications for the fetus, and so forth. And we can start the first slide. Oh, I have the thing. How do you like that? At least they're not backwards. I thought I had them in the wrong way. Okay. I want to start off by speaking about the basics. What is it? First of all, we know that the spirochete of Lyme disease is present in the bloodstream at certain phases during the infection. More so, obviously, in the beginning of the infection, and some people feel that once a few weeks to months have gone by, the spirochete is no longer blood-borne. I was participating in blood culture studies many years ago where we found that spirochetemia is present even late into the illness at certain times of the day and certain times of the month. The spirochete, after becoming blood-borne, does go back into the tissues by invading between and perhaps even through the endothelial cells, and therefore it's not surprising that transplacental passage does occur. We don't know of any barrier in the placenta that will be effective in blocking microbes from entering the placenta and into the fetus, so the potential for an infected mother to transmit her infection to the child definitely exists. From a pathological point of view, when you study fetuses and placentas of infected mothers, you find that spirochetes are present in the placentas and in fetal tissues, that in the placentas you can see no inflammation other than some plasma cells. In the fetuses we found the spirochetes in liver, heart, kidneys, the spleen, the brain, the bone marrow, and so forth. And again, there's no associated inflammation. The importance of this is that when looking for the spirochete, you have to rely on special staining, trained pathologists, and people who are very diligent and spend a great deal of time. These are not the kind of organisms that show up on routine staining as is done in routine autopsy and placenta studies. On a gross level, there have been reports of cardiac defects, neural defects, syndactyly, growth retardation, and even intrauterine death. Now, I want to go through some studies that have been published. The Southampton Hospital, where I practice, has really done the most published reports, thanks to Alan McDonald, who's a real leading man in the field of Lyme disease. But they've reported some studies that really have gone ignored, and even of his own press. There are two parts to the study that he reported upon. The first part was a 7-year retrospective and 3-year prospective study of perinatal autopsies where the fetuses and so forth had passed away for any reason. This is not just Lyme disease. In just counting this, there were 24 fetuses in that hospital, and of those 24, 4 of 24, or 20% of the perinatal deaths had the presence of Borrelia in the fetal tissues. This is just a random survey. This is not directly looking for Lyme disease. The second part involved 6 other cases. 6 other cases of gestational Lyme borreliosis, and these were patients who were known to have gestational Lyme. Of the 6 patients, 2 were treated with antibiotics. The mothers were treated during their pregnancy. Of the 2 who were treated, one had a clear placenta, the other one had spirochetes within the placenta, but the children in these 2 instances have been well and continue to do well. 2 of the 6, there was neonatal sepsis. The babies were treated after delivery and successfully so, and 2 remaining cases, there were perinatal deaths. One baby died 30 minutes, another one died 4 hours postpartum. Clinical findings are very interesting. Of 15 well-documented cases in the mother, only 2 of the mothers were seropositive. 1 was borderline serology, and 12 were seronegative. These serologies included IFAs, analyzers, and were sent to reference labs as well as a laboratory in Southampton Hospital, which is a good lab. Of those 15 mothers, less than half presented with erythema migrans. Interestingly, and this is something that's not, again, paid much attention to, in those patients whose pregnancy was followed and delivery was followed, there were 8 of those patients. 4 of the 8 had toxemia. Is there an association between toxemia and borreliosis? I don't know, but that's another thing that needs to be studied further. Recurrent abortions. There's a patient, for example, who had abortions times 3. One abortion occurred at 3 weeks of gestation, 8 weeks of gestation, so forth. One of the fetuses that resulted from this abortion was studied and borrelia was found. Another patient had recurrent abortions times 2. The mother was seronegative but was culture positive for borrelia. The mother was then treated with amoxicillin and probenecid for 6 months and then went on afterwards to have successful pregnancy and a healthy child. So here's a person who had recurrent abortions for no apparent reason other than finding she had Lyme, treated for Lyme, and her pregnancies were successful. Another report that McDonald had made was that one mother's breast milk was tested and was found possibly to contain Borrelia burgdorferi. The characteristic histology was seen, however, he could not get the organism to subculture. So whether this was a fluke or an indication of something real, we don't know, but I do want to bring it up because many times pregnant women say, I have Lyme disease, should I breastfeed? Until we know better, my personal recommendation is you should not breastfeed until we have more information. Now in terms of the fetus, there's a great deal of variability. There's a wide spectrum, in other words. It goes from intrauterine growth retardation, hydrocephalus, hyperbilirubinemia, cardiac abnormalities, neonatal respiratory distress, neonatal sepsis, fetal and perinatal deaths. Manifestations in the newborn may appear late. In 2 patients, signs of Lyme appeared at 4 months of age and in some even later on. McDonald did a very interesting, and I think landmark study of sudden infant death syndrome. What he did was, without getting too elaborate, he went to other pathology centers in New York State and studied babies who died of sudden infant death, where they were autopsied and no other abnormalities were found in these babies to explain their death. And just randomly picking 10 cases, 2 of the 10 showed Borrelia burgdorferi in the brain tissues. So again, he quotes the spectrum of everything from not being able to hold a pregnancy, to holding a pregnancy but having abnormal babies, to having normal babies but born infected, having normal babies born well but showing manifestations later, and even babies born well, living well, but then dying suddenly, and then after death, finding an autopsy they indeed had Borrelia. Appropriately so, there are some quotes from the syphilis literature that seems to be true in gestational Lyme disease. And the more you study syphilis, the more you see the parallels from the pathologic point of view. Number 1, asymptomatic, seronegative mothers may bear affected children. McDonald's article showed this very, very well, and this is published, obviously, in the syphilis literature. Number 2, seronegative results are untrustworthy, and serological status of the mother is useless to predict the status of the fetus. Third thing, gestational infection may only appear as a tardive manifestation in the child after birth. In other words, you have a mother who is not properly diagnosed or treated, gives birth to a child who appears well, but later on something is wrong and you find it relates back to gestational Lyme. And number 4, repeated unsuccessful pregnancies may be a diagnostic clue to a maternal infection that otherwise is unrecognized. Now that we know there's potential for big problems here, what do you do for treating a pregnant patient? Can the pregnant mother take antibiotics that are not harmful to the fetus? Well, the answer definitely is yes. Unfortunately, the best treatments are not known. We do know what does not work. For example, no treatment we know is associated with trouble. Penicillins, for example, plain penicillin G, even given intravenously, has been associated with some treatment failures, especially when given for short courses. But we do know that successful outcomes are possible and actually the norm if currently recommended aggressive protocols are followed. For example, the medications in pregnancy can include amoxicillin oral. We've also successfully treated pregnant ladies with amoxicillin combined with erythromycin, and again, no adverse outcomes on the baby were found. We know that second and third generation cephalosporins can be used if you're careful, and these third generation cephalosporins such as cefotaxime and ceftriaxone have been used successfully in pregnancy, again without any obvious adverse effects on the children. Unfortunately, for all these antibiotics, the dosages have to be high. Just as there's a blood-brain barrier where you don't get high levels of antibiotics into the central nervous system, there appears to be a placental barrier for antibiotics. And for example, only 20 or 30% of ingested amoxicillin or even intravenous amoxicillin will cross through to the placenta, and the numbers for cephalosporins are roughly the same. What I always recommend, and I do very, very frequently, is I will document serum levels of the antibiotic, peak and trough, in any patient who's pregnant who's on long-term antibiotics. Now the duration of treatment obviously is another big area of controversy and lack of information, honestly. We know that it's been long observed that in disseminated infections, short courses of antibiotics are unsuccessful. Clinical data, antigen capture data based on cultures and other techniques support the need for more extended courses of treatment. The end point being the patient is free of signs and symptoms of active infection, however long it takes, in order to prevent relapses and recurrences later on. Now, in pregnancy, successful outcomes are indeed possible. I'll give you some examples. 3 of my patients had Lyme disease, were treated successfully, became pregnant after the fact, and indeed went on to have normal children, normal pregnancies, and no troubles. Another group of my patients were under treatment for Lyme disease and inadvertently became pregnant during the course of their antibiotics. The antibiotics were continued on these patients through the pregnancy, and despite ongoing active Lyme in the mothers, even to the point of delivery and afterwards, and positive antigen detection in some of the mothers post-delivery, all of these children are well. Apparently the antibiotic had protected the children from becoming infected if the antibiotic was given in a high enough dose and for the entire duration of the pregnancy. I have patients who were pregnant and developed Lyme disease during their pregnancy. 3 patients in this one series, and I'm sure there are more since I pulled this together. Of the 3 patients, there were 1 in each of the trimesters. The mothers were treated promptly, and in no case was there any adverse outcome. So again, we know medications that don't work in Lyme. There are some that seem to work, but the bottom line is you have to be aggressive. You have to aggressively diagnose the mothers. You have to aggressively treat the mothers. And this includes treating on tick bite, especially in endemic areas. And it includes watching the mother and the baby afterwards for signs of Lyme. It includes having a high index of suspicion in case something is not right. Is it related? This is exactly the time we need to use any and every antigen detection test and method that we have available, and even a few experimental ones, just to be sure of what's going on. Now, to emphasize this, I want to go over my case report. You can read this together. Hopefully I can read it. I have a 34-year-old patient with Lyme disease. She remains symptomatic despite 7 months of therapy with amoxicillin. Her therapy is therefore changed to cefotaxime, 6 grams daily through an IV. After 2.5 months of continuous treatments, at this time she's still symptomatic, she inadvertently became pregnant. She was still symptomatic at that time. The cefotaxime was continued for 4 more months to the midpoint of her pregnancy and was followed by oral amoxicillin. On the oral amoxicillin, whatever ground she gained from the IV, she started to lose. We would promptly turn her to cefixime, and that was continued through to the delivery. Postpartum, the Oberdorfer was found to be present in her placenta by histologic staining by Paul Duray. Fortunately, her son, who as of today is now 5 months of age, remains well. Antigen detection data on the baby done every single month through the urine capture test has been negative. The mother, who is still ill, was initially urine capture negative, and now she's capture positive, symptomatic, and back on intravenous. This case report confirms the ability of Borrelia burgdorferi to evade the host defenses and to evade antibiotic therapy, including prolonged aggressive courses of intravenous antibiotics. It also demonstrates that Borrelia burgdorferi can cross into the placenta despite such ongoing therapy, and that there must obviously be periods of sparcutina even late into this illness, a fact not thought to occur in humans. This is a lot of hot stuff. I mean, here you have a patient who, by the conservative methods, was vastly overtreated, not just 7 months of oral antibiotics, but now 6.5 months of intravenous, and 7 more months of oral. But look at this. After most of the therapy was given, after she became pregnant in placenta form, we still had Borrelia in her and in the placenta. It also shows that aggressive treatment and not chickening out halfway through and saying, my God, you better stop. Pursuing it based on the mother's clinical findings, you can get her through the pregnancy and have a good outcome. Okay. Treatment recommendations. Again, these are my treatment recommendations, and so you have to take it like that. For the mother, if there's a tick bite, what I call a high-risk tick bite, I'll use oral antibiotics for at least 30 days and perhaps longer. What is a high-risk tick bite? Well, basically, the mother being pregnant, in a reverse sense, makes it a high-risk tick bite. Patients who come from the Northeast, from the Central Midwest, from the West Coast where Lyme disease is endemic, obviously they are at high risk, even if infection rates in the ticks are low, because you can't tell if that patient got infected. If the tick is engorged, it's definitely a high risk. If the tick was not properly removed, if it broke on removal, it's definitely a high risk. I don't believe in the data about needing 24 or more hours of attachment. I personally, in my practice, I know others have also, had cases of Lyme disease develop after short attachment periods of 5 hours or so. Again, the tick could be on 1 hour. If it's improperly removed, if it breaks open and spills the contents into the wound, you have a high likelihood of an infection. So my bottom line recommendation, tick bite from endemic area in a pregnant mother should be treated for at least 30 days. Because the Borrelia does have a 4-week regeneration cycle, and because you want to blanket that cycle with antibiotic treatment, I will often treat for as long as 6 weeks, even on a simple, what appears to be a simple tick bite. For everything with migraines, that's asymptomatic. We know now, and you heard a presentation yesterday from Pat Coyle, that even if it's asymptomatic, it's still a disseminated infection and still likely to the central nervous system. I'll treat the mother with oral antibiotics for at least 6 weeks for an asymptomatic everything migraines. However, I'll make sure that she's on treatment at least through to the 4th month, even if that means more than 6 weeks, because I do want to make sure that you're beyond the period of organogenesis in the baby. A lot of trouble in deciding if the 4th month should we stop. One of the ladies in my case reports, we did do that. She became symptomatic. She got obvious synovitis during that. We put her back on antibiotics for the rest of the pregnancy. And she's still symptomatic off and on, but the baby again as well. How about symptomatic Lyme? I'm not breaking down to early, late, disseminated, whatever. Any Lyme symptoms, and as long as it's disseminated, but your body's reacting to it, it must be disseminated throughout all tissues. At that point, I'll give intravenous antibiotics, again, for at least 6 weeks to blanket and bracket the whole regeneration cycle that we know of, and at least until the patient's symptoms are controlled. Then I'll follow by oral antibiotics at least through till term. Treating the child, neonatal sepsis is very often treated even empirically in children with cefataxime, which, as you know, is an excellent drug for Lyme disease. So my recommendation for the child is to treat the child with appropriate doses for at least 6 weeks, then switch if possible to oral antibiotics for at least 6 more weeks, with extremely careful observation of the child for years, not just for weeks or months, but for years, and if possible, doing antigen capture tests as they become available. As I mentioned before, I don't recommend breastfeeding if you know the mother's been infected. I don't have much data to support that, but I'd rather play it safe and be cautious. Let me go through the conclusions. From the research data that's been published, we know that there's a positive association between seronegativity and adverse outcomes. In other words, the adverse outcomes of patients are more likely to be seronegative. So seronegativity, once again, seems to be a more serious illness. Number 2, manifestations are protean in the mother and the fetus and the newborns. In other words, they're not very specific. Diagnosis requires a high degree of suspicion, careful clinical assessment, and if the situation is appropriate, diligent Borrelia burgdorferi detection by histopathology, by culturing, and by any other antigen capture methods that have been validated and are available. Third point, manifestations in the child may not appear until hours, days, or even months, and unfortunately in some cases years after birth. So lifetime follow-up is important. Number 4, the worst outcomes have occurred in untreated mothers who acquire Lyme disease during the first half of pregnancy, and also in untreated symptomatic women who become pregnant at the time that they're still actively infected. Number 5, effective treatment must include the right drugs, and it shows you there are not that many to choose from. They have to be given in high and confirmed doses based on blood levels and for a long duration of time. If this is done, the adverse outcomes related to Lyme in the gestational period can be prevented. And finally, despite the low percentage of adverse outcomes, because here in endemic areas you don't hear that much about gestational Lyme disease, and I'm sure a lot of cases are being missed, but nevertheless, it's fairly low percentage. Nevertheless, despite this low percentage of adverse outcomes, because the number of cases of Lyme disease are high nationwide and are increasing, we need to become more aggressive in the diagnosis, in the treatment, and in, of course, the study of this. And finally, I have to say, we really have to focus on this and do much more study. And as the case I showed you today presents, a lot of different issues are covered by that one topic alone, by that one patient alone. And just as important as learning about the tick habitats and about what vectors carry it and so forth and so on, we have to study the pregnant patient and her baby. Thank you.
Thank you very much, Joe. There's no question that we need a national registry for Lyme disease in pregnancy cases. And it appears perhaps the only way to get one is to institute one and develop one ourselves. Our next speaker is Dr. Ron Schell, who is professor of microbiology and immunology at Wisconsin Medical School. He's going to talk about the variecidal assay and measuring immune function. How are you doing? Good.
We don't need that phone, I don't think. I have to ask this question. Can you hear me in the back? I guess you can hear. That's good. Let me tell you the direction I'm going to go so that you have an idea. I'm going to talk very fast. I feel like I've lived in New Jersey for 4 years, so I have the right to do that. Okay? But I am going to go very fast because we're short on time, and I cover about 45 slides looking at variocidal antibody. And we'll go fast. But first of all, you want to ask, why haven't you heard about this type of antibody before? Well, in some respects, I have to watch out there at the microphone. You have heard about it in this conference. Dr. John Mays talked about it a little bit in terms of if you got a Canard vaccine, you're going to look for immune status in those people to see whether or not they actually produced the antibody that could kill B. burgdorferi. So that's variocidal antibody in one form. They use it for growth inhibition, and I'll cover that in a few minutes. The original finder, or the person who first published this, was Charlie Pavia, who's actually the very next speaker, who documented this in the Journal of Infectious Disease about 2 years ago. Subsequently, Stephen Loveridge, John Schmitz, and Steve Callister, they're associated with my laboratory, have done more work on the variocidal antibody to see whether it will fit into immune status and whether or not it can be used as a diagnostic test. Basically, what it really comes down to is a very simplistic thing. And you may ask why, in fact, it was missed. Well, let's kind of describe how it's done first. Really, we can grow in our test tube, and we can place them in contact with immune serum, whether it's animal or human serum, add complement, and then within about 6 hours, actually occurs before that, Borrelia is killed, and you will see blood formation, much like Claude showed you yesterday and some of the people from the Rocky Mountain Institute, but they do die. And there are measurements to show that they die. For those of you who are maybe are not the lay persons in the audience, well, what good is that? It could possibly be used as a diagnostic test, which I'll get into to try to show you. But at the same time, we know that cell-mediated immunity may play some part in Lyme disease, but probably a minor part in terms of actual protection. So most vaccines that are being developed will focus on this antibody in some form to say that would be immune status. So if you're going to get vaccinated, maybe 2 years later you're going to want to find out whether or not you are in fact have protective antibody. You will use the variocidal antibody in some format to say that you still have antibody. If you look at it, so if you have the organism, the Lyme spirochete interacted with immune serum and complement, you will see this occurs. It forms blibs. If you use different types of measurements, you'll find that it becomes non-nodal. You find that it cannot pick up tritiated admin. You can't add more media to it, or you can add more media, and you find that you can't grow it. And if you look at control systems, the top two, A and B, are basically Borrelia in BSK or normal serum, and in C it's with the immune serum and complement, and in D is the strangulation effect, we call it, or this growth inhibition assay that now Alan Barber has coined in the article that follows ours in the January issue of the Journal of Infectious Disease. But you'll see this strangulation effect, and I'll come back to that point a little bit later. What you're not seeing on this slide is a very important part. I can see it from here, but there's a top line, and what it does say that the borreliocidal antibody does not correlate at all with IFA or ELISA. You say, well, what good is it? That's your first reaction, that doesn't correlate with it. Well, maybe the ELISA and the IFA have got problems, which we know in the literature that certainly is there. But what the borreliocidal antibody does correlate with, if you look at the pathogenesis of the organism in the host, you find that it multiplies, borreliocidal antibody begins, and as the organism or host gets rid of the organism, gets rid of Borrelia, you find out that the borreliocidal antibody decreases. That suggests it may be a prognostic indicator of successful therapy. You get treated, you lose this antibody. If you're familiar with the syphilis literature, you'll realize that the TPI is a forerunner maybe of this thing, or that the FTA-ABS is analogous to the ELISA and the IFA that's we use for Lyme. They stay with you basically for the rest of your life. They can be influenced by therapy, but they stay with you. So this antibody represents a new concept in Lyme disease, not only for immune status, but really it can be used in a diagnostic way, and that's what I'm going to try to show you that it can be done. So borreliocidal antibody, I feel, is here particularly for immune status. Is here to stay. When we vaccinate, whether we're vaccinating dogs, we're going to vaccinate humans, we're going to use this to assess whether or not you have antibodies that lead to protection, or that you have sustained protection so that you can be revaccinated again. Let's look now and see whether or not the borreliocidal antibody can actually be used as a diagnostic test. And I'll try to make it very simple, and I'll go very fast. If you've got questions after, we can talk about it later on during the day. But what this assay is, this was published in the Journal of Clinical Microbiology about a year and a half ago. At the top, and I'll try to condense it in a form, what it basically says, you can take a patient or non-patient serum, place Borrelia in contact in small quantities, incubate it for a short period of time, and then by a series of measurements, either the Coulter counter or simulation counter or dark field microscopy, you can determine whether or not it grows in normal serum, because it should grow, or it's killed in immune serum because there's killing antibodies there that should kill it. This is sort of an archaic way of doing it, and I will finish up in the end trying to show you a faster and more expedient way to do it. But right now, we know that using dark field, you can immobilize it. Using simulation counting, you can say that it doesn't incorporate tritiated admin. And using Coulter counter, which is just basically another particle counter, you can say that there's less organisms in a medium that contains an immune serum, so there will be less there. We know from what has been already published that serum from humans infected with Burgdorferi are not killed in normal serum. And this is shown on the next slide. This was published in the Journal of Clinical Microbiology. This is a control, and this can be either interchangeable, normal serum or BSK. And you notice that the organism does multiply in BSK, and it multiplies in normal serum, and actually multiplies better. So we know at this stage that it can grow. Immune serum has no inhibitory effects against it. We can pull immune serum and replace BSK because BSK is actually not under the control. If we take B. burgdorferi, we find out and place it in contact with Lyme patient serum. And again, this was published in the Journal of Clinical Microbiology. The control is normal serum. And we look at different patients that have varying degrees of from arthritis to just EM. You find out that they have varying degrees of killing antibody. And you say, well, that doesn't look too impressive yet. But look at these first. The 3, 4, 8, and 9, and 10 are from individuals who have arthritis. And there's a lot of killing activity. If you look at 2, 12, and 13, they're from individuals that have an EM rash. If we've got convalescent serum from these individuals, borreliocidal antibody increases, we detect more killing of the organism. And then there are varying degrees of other individuals in here, and I'll come back and show you more data in a few minutes. So you know then that convalescent serum, it increases variocidal activity. The things that Steve Schuster said yesterday, you realize there's going to be no perfect test. And you've got to get that through your heads, that it takes time for the immune system to make a response. So in 10 days, you're not going to find the antibody. It's going to take time. So even with the variocidal assay, you're not going to find results one day after infection with the tick. We're only going to find it with an IFA or an ELISA. It will take time to do that. But it gradually does develop. We also found out that variocidal activity was not detected in patients with other diseases. And this is a very important aspect because IFA and ELISAs have cross-reactivities. And again, this was published. So that if you look at individuals that have Rocky Mountain spotted fever, relapsing fever, mononucleosis, syphilis, rheumatoid factor, antinuclear activity, you notice that there's no killing activity. You do this with the ELISA or IFA, you're going to see activity. So these results then suggest that the variocidal antibody may be more specific than is currently available diagnostic tests that are out there. And that's all we're saying at this point. I'll try to give you more data. In the January issue of the Journal of Infectious Disease, Steve Callister published an article that was entitled Characterization of Variocidal Antibody Response, a Serodiagnostic Test. And what we wanted to accomplish in this article was to characterize this effect more, to see whether or not we were dealing with it, what we were dealing with. Steve listed 40 patients that have a CDC definition, the old definition of Lyme disease, keeps changing. But you'll notice that individuals that have EM, there were about 23% of them had killing activity. If you had multiple EMs, then you get to 46%. If you had joint pain less than 60 days, it went to somewhere around 64% killing. And the longer the duration in the symptom, the more killing activity you saw. So severity is correlated with duration and the symptoms of the disease, the development of variocidal antibody. To prove that it's an antibody to some degree, there might be some arguments about this, but what Steve did do, he took a Lyme patient. This is a Lyme patient here that can have killing activity compared to a normal serum where they multiply. And he treated that serum then with anti-IgM. So this was an early patient, and he aggregates the effect. So we know that M can combine with complement and can kill, and when he takes it out, he does not have the activity. He repeated this with a later Lyme disease patient, treated it with anti-IgG to get rid of total immunoglobulin G, and then aggregates the effect. So you know antibodies form. This is not a VDOL test. This is a specific antibody we're looking at. So variocidal activity was aggregated when Lyme disease serum was treated either with anti-human IgG or IgM. This is important because Steve also showed that if you've got normal serum, it really multiplies again. If you've got a Lyme serum, it suppresses it. And if you treat that serum with whole immunoglobulin, then repeating what we just showed you, it takes away or aggregates the activity. If you treat the serum with gamma 1, which we now know contains part of the variocidal antibody, the activity is aggregated. If you look at other immunoglobulin classes, 2, 3, and 4, you see that you haven't aggregated the effect. But in fact, with G4, you may in fact have taken out blocking antibodies and increased the amount of killing to prevent other antibodies that would prevent variocidal antibody from killing. And this is not unusual. When you get exposed to Borrelia, you make a response to almost 20 some odd antigens that are on the surface of that organism. That means you can compound that by the number of antibodies you produce. If you can get rid of some of these, you're going to increase the specificity of the test. To prove that this antibody really has an effect in humans, Steve took some of these patients. We don't recommend doing this type of thing, transferring it into animals, but these are Lyme patients with token-immune serum, transferred into hamsters that develop arthritis and prevented or delayed the onset of arthritis compared to a control. So we know that it represents immune status also, that there's material in patients' blood that can prevent arthritis, at least in a hamster, and it can be used, we're looking at, as a serodiagnostic test. You've heard arguments about, heard evidence that outer surface protein A is the vaccine of the future. Maybe it is and maybe it's not. I'm not one of the believers that it is, because there's a lot of heterogeneity in OPS-A. But what this says, that when you take some of these Lyme patients and take outer surface protein A, you can, this is with it not absorbed, sort of the non-shaded lines, the white lines, you see you have various vital activity. But when you absorb out with OPS-A, you remove some of the activity, but you still have various vital activity in there, minus OPS-A activity. And this simply says that we've removed OPS-A activity. So various vital activity can occur in the absence of anti-outer surface protein A. That's also collaborated in Alan Barber's article that appeared after ours in the Journal of Infectious Disease. This is not the final conclusion, because I got two conclusions. I'll show you the conclusion of this one. We know that serum from humans infected with B. burgdorferi contain borreliocidal antibody. That's important. We know that these borreliocidal antibodies can kill B. burgdorferi relatively rapidly. We know that the borreliocidal antibodies are either M or G, M early, G later. And we know that borreliocidal antibodies can be detected in patients with localized erythema migrans and disseminated Lyme disease. How good is the sensitivity? I don't know yet in terms of detecting late disease, or excuse me, early disease. But we know it's pretty good detecting later stages of the disease. One of the problems with the borreliocidal assay is that it's done in a test tube, and it's not available to New Jersey Medical Shores or Medical Center Hospital or to Hahnemann Hospital, because it's got to be done with a live organism, and it's done in a test tube. To get back some of the problems, or to alleviate part of that, we changed it to a technique called flow cytometry, which is relatively fast. Now, I want to speak about this in terms, I want you to look very carefully at Alan Barber's article called Growth Inhibition that appeared in the Journal of Infectious Disease. If you look and are very careful and analyze it, you'll notice that Alan has to use an inoculant around 10 to the 7, 10 to the 8 organisms. We're talking 1,000 organisms putting into this machine to detect whether or not you have borreliocidal antibody. What that means in common sense terms is you have to have less antibody to detect killing. If you've got 10 to the 7, you have to have a lot of antibody to cause either agglutination or killing with that type of inoculum. With flow, it can count individual organisms, individual borrelia. The other thing that Alan presented in his article, he does the testing his called growth inhibition without complement. But in the same article, it says that complement embellishes or makes the test better. We use complement all the time. The other thing about Alan's assay, it takes 72 hours. This takes 17 hours in which to accomplish. Out of 16 hours, you're doing absolutely nothing because you're home sleeping. Because the machine is doing the work for you. So we do the borreliocidal assay now, not by simulation counting, not by Coulter counting, or not by dark field, but by flow cytometry. So the borreliocidal assay now is done by flow. I don't want to get you into the technology of flow, but I will show you we can find it. Top slide shows that's BSK, and you'll notice that it has no intensity and no particle size, basically. As you add borrelia, because it has size, you can eventually pick up its size. If you label it, it then picks up intensity of fluorescence, which is shown here. So we can label borrelia, that's what I'm trying to tell you, and we can pick up that intensity of labeling. This is what you would see. Now, the machine, you've got to realize, is a lot more sensitive than you are looking into an IFA. So there's borrelia in normal serum with complement. There's borrelia in immune serum with complement. And by the way, there is a distinction. The machine can distinguish it, but we can't quite readily. And notice it's getting more intense. So the machine can distinguish immune serum plus complement, but I can't quite do that when I look at it in a microscope. This slide is kind of complicated, but I'll try to show you what it does. We took normal serum, and notice these peaks are relatively straight because the organisms are growing. We put it in around 5,000 organisms, and it multiplies. That's why the peak is getting taller. And at the same time, it's not quite in focus here, because I can't read it quite. you notice that in normal serum, it just simply multiplies, but there's no change in fluorescence at all. No change in intensity moving it that direction. But this slide is immune serum, a Lyme patient. 2 hours after inoculation, there's no difference. At 4 hours, there's a slight difference in the picking up fluorescence, and that's showing up here. On the back, probably cannot read that. But as you go along, here at 16 hours, you notice that there's already a shift in the ability of that organism to pick up fluorescence versus the control. And it's not alive. And it picks up more, and you got more intensity. And finally, you don't find very much of it, except there's a shift in fluorescence. There are 3 indexes or parameters to measure biliary cycle. One is called mean channel fluorescence. It's the shoving of that intensity that way, which you can see from here and here, that they're slightly in a different axis. There is a percent tapering up of fluorescence that says that it takes up more fluorescence here than it does over here. And there is the actual counting of the organism. There are more organisms here, and there are less here. There are 3 parameters by which to evaluate that. This slide is not quite in focus, and it's not quite developed. They developed it pretty fast, but it says the sample and the controls are prepared basically in 10 minutes. They're incubated for 16 hours after that. They're put into the flow for exactly about 10 minutes. Actually, it's a little bit less than that. And you have a readout almost instantaneously. To show you some common data, what it means, this is hamster data here. On this side, flip right to the left of the arrow, and on that side is human data. I'm going to show more human data in a second. But what it says here, and as I look at it, is that normal serum, the organism can multiply in the presence of immune serum it can in a hamster. Same thing happens in a human. Multiplies in normal serum, suppressed in Lyme serum. If you look at other measurements, whether you're using events per second or mean channel fluorescence, because they're dead, these measurements are actually lower than the controls because you pick up more fluorescence and you have a more change in the mean channel fluorescence. And it correlates. Human data and hamster data correlates. This one you should be able to read a little bit clearer. Steve went and obtained 10 Lyme patients that have myalgia, EMs, Bell's palsy, neurologic symptoms of joint swelling, and they're shown from here 1 through 10, and 10 normal controls. And notice that the percent label of fluorescence that they take up is 8.1, and it's 42.6%. Clearly a significant difference between the Lyme patients and the so-called controls. So we know that what we've seen previously, what Steve has already published, can be done in the flow. What the data actually looks like is, as you get a printout form, it says, here's normal serum with a nice 30 peak, well-defined, on an exponential curve, well-defined. And as you add either M or G, that curve gets changed differently. Read out very fast. It looks very high-tech, but it's very simple to do. And again, I think this is an IgG individual that has IgG. Again, the curves are different than they would be with a normal individual. Now the issue, depending on where you are in the country, some people want sensitivity, other people want specificity. We focus this assay basically looking at specificity first. If you're Lyme disease, I don't want to know if there's more Lyme disease in the state of Wisconsin. I want to know if you've got it, do you really have it? So we want to focus in on specificity. So what we did is that Steve collected, and they call this assay in Wisconsin called the Gunnison Lyme test because that's where Steve Callister developed it. And it's at the Gunnison Medical Foundation, La Crosse, Wisconsin. So Steve collected serum from an individual that were normal, that he recruited in an endemic area. So there were 107 individuals. The number of negatives in this test were 102. There were 5 positives with a specificity of 95%. If you use the same syrup with RFA ELISA, you are going to find cross-reactivity. If you take them and examine other patients that have syphilis, Epstein-Barr virus, lupus, a rheumatoid factor, or have anti-nuclear activity, notice there's 49 syphilis, no activity. Epstein-Barr virus, no activity. Lupus, no activity. Rheumatoid factor, no activity. Specificity 100%. Because these antibodies aren't what's killing B. burgdorferi. B. burgdorferi stimulates its own antibody that can kill it. So why should you have so-called cross-reactive antibodies trying to kill it? These cross-reactive antibodies, however, will, in fact, agglutinate it in Allen-Barber's assay, so that you don't gain any specificity. So overall, the specificity of this assay is around 98%. Conclusion then is that detection of the cytal antibody by flow cytometry, which is the penicillin Lyme test, how it's being performed, is a specific serodiagnostic assay for detecting Lyme disease. And it will also be used in the future for looking at immune status. Thank you.
Okay, thanks, Ron. The next speaker is Dr. Charles Pavia. He's Assistant Professor of Medicine and Microbiology at New York Medical College, Director of the Immunodiagnostic Laboratory, and much of the research has been spent studying bacterial and parasitic infections affecting humans with attention to spirochetes. And we'll be talking about serologic findings in culture-positive patients.
First, give you a little background or history that's kind of deja vu-ish. The last time I was in Atlantic City was 17 years ago. I attended a annual microbiology conference sponsored by the American Society for Microbiology. And this is the cover of the program. And if you notice, look at the focus here. It was held May 2nd through the 7th of 1976 here in Atlantic City. And one of the sessions held on May 6, 1976 on cell-mediated immunity in the convention hall. And paper number E100 is titled In Vitro Response of Peripheral Blood Lymphocytes from Syphilitic Rabbits. One of the authors is C.S. Pavia, which is me. J.D. Foles was one of my PhD advisors, and Joe Baseman was my other PhD advisor. Below that, I've added something that wasn't on the program. It's an excerpt from the first Lyme Disease International Symposium, which was held in 1983, I believe, in New Haven, and the proceedings were published in 1984. And this is a quote from Alan Steer, I forget what page it is, on Clinical Picture. It says here, during the following summer of 1976, we identified for the first time patients with the skin lesion, confirmed its similarity to ECM in Europe, and followed the patients prospectively. Many of them subsequently developed arthritis, but some also acquired neurologic or cardiac abnormalities. Thus, Lyme arthritis became recognized as a complex multi-system disorder, and the name was changed to Lyme disease. So I thought this was like an interesting kind of coincidence that this is 17 years to the day when I first spoke here, and it occurred at a time when Lyme disease was just starting to be recognized. Well, it took me about 8 years before I finally decided to get out of the syphilis field and enter into the Lyme disease field. So, but the two diseases do have a lot of similarities, and it's worth knowing both of them. And actually, I have the honor of lecturing to our medical students on the spirochetes, and of course, I cover both of them to a much larger extent. Well, now getting up to date, our medical center 4 years ago established a Lyme disease diagnostic center. There was a lot of hoopla about this. There was a need perceived by the county for having some facility available to people on a walk-in basis. And this was established to accommodate people who work or have regular routines. And the clinic is open from 4:30 to 6:30, Monday through Friday, during the peak Lyme season, which is usually June through September. And you don't need an appointment. You just walk in and you get worked up for Lyme disease if indeed you have it. And
The first year was 1989. That year we saw 3,000 patients. Of those 3,000, probably about 250 to 300 had the classic EM rash. Of those 200 or 300, about 50 to 75 enrolled in some various therapeutic trials and experimental studies related to Lyme disease and its diagnosis and its treatment. Some of those patients I will be talking about. In subsequent summers, we've had a similar type of experience. We've generally enrolled 50 to 75 patients for various studies. Most of them are supported by pharmaceutical companies who are interested in testing whether or not their particular drug of the year is suitable for treating Lyme, and comparing it with traditional ones like penicillin and doxycycline. One year we got support from the CDC to look more at the erythema migrans rash and see if we could culture the organism, and also to look at the serologic response, because the CDC was very much interested in acquiring a significant bank of sera that they could use to distribute to whoever wanted it to sort of centralize or get an idea of what sera from a well-characterized and well-known endemic area how it can be used in comparison to, say, sera from a non-endemic area where there may be problems in its specificity and sensitivity, and use it for various purposes to help improve the diagnosis and understanding of the disease. Well, that's the background, and that's probably sufficient. All right. This is a slide of Borrelia burgdorferi. It's one from my laboratory. I like to show it periodically just to remind people of what it looks like. Most people probably know what it looks like. But here you get to see a large number of them. Most of the slides you see at this meeting depict a few. But this is a growing culture. We grow the organism routinely now for over 7 years, and we grow a lot of it. And we periodically monitor its growth. And we use this is an acridine orange stain, which stains the nucleic acid and proteins of the organism. And we shine UV light on it. It usually has a green color, and it resembles immunofluorescence. So you can really see the organism nicely. All right, little geography lesson, as if we need it, but puts things in perspective. This is the East Coast area where Lyme disease is endemic, and some of the hot spots are indicated by these red dots: eastern Long Island, the central shore of New Jersey, and our little area here in Westchester, which is just north of New York City. It's kind of interesting driving down here to the conference in Westchester, crossed over the George Washington Bridge, went through the industrial area of Newark and the airport. Then getting down here is a nice little scenic area where probably there's plenty of deer and plenty of Lyme disease as well. And here we are down here in Atlantic City. Should have updated this slide, maybe put a few slot machines here so we know exactly where we're located, but anyway. So this shows you a little bit of where Lyme disease is a problem within a 200-mile radius of Atlantic City. The patients I'm talking about today come from Westchester County, right here. All right? That's one of the criteria for entering into these studies. All right? Patients outside Westchester can come to the clinic, but we don't generally include them in the studies because of some of the strict criteria that are used for including patients in studies. Again, this isn't a surprise. This just to reinforce the high-risk area and how the clinic is very busy during the months of June, July, August, and September. Then, after the peak summer months, the clinic is open 1 day a week for the rest of the year to accommodate patients for follow-up, because there's a tremendous amount of follow-up involved in these patients, as are present out in the slide, and also for people who may acquire Lyme disease in the in a period where it's not usually frequently acquired during the winter months. Okay, what do we have here? All right, the classification schemes for Lyme disease. I just want to reinforce, I'm only going to be talking about erythema migrans. That's it. Nothing really about symptoms. This is strictly about erythema migrans. Here, I'm going to show a couple of rashes. These are rashes I photographed from examples of some of the patients we've seen. And there's some diversity, so I thought it would be interesting to show them. This is a rash that has somewhat of a more central red area, followed by a blanching or whitening area, and then the outer area is that typical red rim. Here's another rash that was on the front of the leg. This is on the back of the leg, just behind the kneecap. And again, you have this expanding red annular lesion. The previous slide, it was sort of an elliptical appearance. Because of the location here, it's kind of an odd-shaped rash. Here's a rash on someone's shoulder. I can tell you it was about the size of a small dessert plate, and it was beautifully circular with a central tick bite. But it has, again, this interesting array of colors. The central area was a dark pink to reddish color, and then you have this blanching occurring outside that, followed again by another red or pinkish ring around the outer edge. Here's a rash on someone's neck that has a more of a, it's somewhat hard to see here, but it has a vesicular kind of appearance with some fluid oozing out here, and it also has a very odd shape, but fairly uniform in its diameter. Here's a secondary lesion, almost contiguous or somewhat adjacent to the initial lesion. And here's some lesions in the groin. Here's an erythema migrans rash contracted by an entomologist. This is one of the hazards of the job of being an entomologist and tracking the ticks of Westchester County. It's a very good friend of mine. And he had the erythema migrans rash here. And finally, a patient seen in our clinic had the rash here in the groin area. Again, very elliptical. The coloring isn't all that great, but it's almost uniformly red with some blanching around the outer border and then some more red at the outer edge. Okay, finally, diagnosis of Lyme disease. Just a reminder, it's clinical grounds. If you have the erythema migrans rash, plus or minus the symptoms, this is not too difficult to do for the physicians in Westchester County or in endemic areas. The problem in non-endemic areas or in areas where it's infrequently reported. The confirmation, or in difficult cases, the establishing of the diagnosis many times relies on serology, usually it's ELISA, immunofluorescence. We resort to immunoblotting if the basic serology is unclear, and the new wave technology of polymerase chain reaction may help further identify unclear cases. Just want to mention briefly, I'll be talking about ELISA results. Just for those in the audience who are unfamiliar with the ELISA, the organism is coupled or stuck to a solid support. If you put the antibody-containing serum from the patient, the antibodies will interact with the virial antigen. You wash the unbound antibodies. Then you come with an enzyme-labeled anti-immunoglobulin. They will bind to the patient's antibodies that are already there, that are stuck to the antigen. And then you wash away the excess antibodies here. Then you use a substrate which will react with the enzyme. And if everything has taken place in the preceding 3 steps, you'll see a color change. And this can be read by a machine, which gives you a numerical value based upon the amount of antibodies present. That's a quick summary of ELISA technology. It's no great difficult thing to do. Now some data. This is some data that I presented at an ASM meeting last year, which summarizes some of the patients we saw in the preceding summer, which was in 1991. This first table is the serologic findings in patients when they come to the clinic on what we call day 0. That's the day they're coming in saying they've seen this rash. Can you tell us if it's Lyme disease? And what we've done These are the people who fit this criteria that we believe had the erythema migrans rash based upon our years of experience of seeing patients there for several years. And of the 65 patients who had this erythema migrans rash, we used an ELISA system, this one by Hillcrest. 38% were seropositive. There were some equivocals. We got up to 50% of these patients to have culture-positive organisms from those erythema migrans rashes. If we use an ELISA by Whitaker, which is an M plus G ELISA, there's 42%. We have an in-house assay, which I developed several years ago. It's called an indirect hemagglutination antibody test, and we saw 43% reacting in this assay. So, and the number of culture positives over here were between 12 and 13. Now, when the patients return 8 days later, after having 8 days of antibiotic therapy, we draw another blood specimen, and we look at their serologic responses at that point. Don't worry about trying to remember what are on the last slide and the next 2 or 3. I have a summary slide after that, which will be the take-home message. Here we have 65 patients start. 38 of them are now evaluable for a number of reasons, and I don't blame them. If the patients are doing well after 8 days of therapy, they don't come back. They'll come back maybe in a month. Well, that kind of screws up the results, so we can't include them here. So of those 65 in this particular set of experiments, 38 came back for the 8-day visit to have the serologic workup. As you can see, there's a significant increase in the percentage in all the assays than we saw on day 0. 63% for the Hillcrest firm, 82 for Whitaker, and IHA was 76. The increase you see here in the number of culture positive compared to the previous slide is based on the fact that we're now including the seroconverters here from the previous slide. There are many seroconverters here who were not seropositive in the previous slide, and that's why in the previous slide we said between 12 and 13 that were culture positive. Now we're including the ones who are culture positive at this stage of their serologic response. These same patients, well now we're down to 33. 2 people from the previous, was it 5, decided not to come back for day 20. And we see this is the best time in our experience for having a blood sample that will be seropositive. We have 70% with the Hillcrest M, 82% with the ELISA by Whitaker, and the IHA had 88%. We have roughly the same, 16 to 17% culture positive. And finally, we have them coming back on the 30th day. And their ELISA results are somewhat similar to what they had on the 8th day, 63%, 71, and 80, and the culture positives still remain between 15 and 17 cases. Most of the time, these are patients who've received either oral doxycycline, penicillin, or in some of the drug studies, azithromycin, I believe, is one of the experimental drugs. And usually these are standard 2-week courses of antibiotics, unless there's some complications. Some people have adverse drug reactions to the antibiotics, so they have to be managed that way. But I'm trying not to, I don't want to include that here because that's not really germane to the point. This is a summary of the previous 4 slides and also includes some more recent data, so the numbers may be a percentage point off than what I actually showed. On the first day visit, 39 to 45% are seropositive by the assays we used. On the second visit, day 8, 66 to 79% are seropositive. The third visit, 70 to 78, and finally the fourth visit, 63 to 80%. We also look at them at 3 months and sometimes 6 months, and that's what this slide shows in a figure form. Here we have the different time points, time 0, 8, 20, 30, and 90 days. And we've broken it up into IgG and IgM. And as you see here, between day 8 and 20 is when the peak IgM response occurs, usually between 70 and 80%. The G response sort of levels off from day 8 to day 30 here with 60%. What do we got here? All right, this is very interesting results when you sort of can do a lot of things with some of the data you get that don't really seem obvious at the time. We've lumped these patients into a couple of different categories to see if they can tell us something. Patients will tell you when they come in how long they think they've had the rash. Well, there's several pages of questions that these patients are asked relating to their possible acquisition of Lyme disease. And one of the questions is, how long do you think you've had the rash? And they'll tell you, and we've lumped them into those who think they've had it less than 7 days, those between 7 and 14 days, and those greater than 14 days. And really, this data is not surprising. Here are the number tested. Only 13% are seropositive at, this is now day 0 data, the day they came in, and a blood specimen is drawn. And here are some of the equivocals. It jumps to almost 50% during the second time period, and if it's greater than 14 days, it's 93%. And by this point, there are a significant number of patients who also have constitutional symptoms and are not feeling very well. And of course, you really don't want them to come at that time. Okay, there are future technologies now, PCR, Western blot. Culture's kind of old, not really future. The future is now, actually, with some of these. Urine antigen and lymphocyte stimulation. I just wanted to point those out because I'm going to show you some PCR and Western blot data that go hand in hand with what we've done here. Again, for those of you not familiar with Western blot, here's a quick diagram of what it is. You put your organisms sonicated onto a gel. You run an electric current through it. You transfer the proteins to a nitrocellulose sheet. It's almost like a sheet of paper that's porous. And then react the sheet with the patient's sera, then add a second antibody which will react with the patient's sera that's adhered to the strips where particular antigens are, and then you use a substrate which will bind to the enzyme, and then it'll give you a color reaction. Here's an example of a Western blot on some of our seropositive early Lyme patients. This lane here with no number, this is just the whole crude sonicate of Bieber-Dorferite. Here are the molecular weight markers. Lane 4 is one of my technicians, all right, to serve as the non-Lyme control. She lives, like I do, in an endemic area. So she's sort of a nice little control to throw in there. And here are the patients. And you can see some very common bands recognized by all 3 patients. One patient here, I believe, is at a slightly later stage or at a higher titer, is beginning to recognize what looks like OSP-B, or it could be OSP-A. The molecular weights here are kind of expanded in their size here. So, but here you can see probably where the flagella antigen is. You see very strong reactivity, and there's also reactivity with several high molecular weight proteins. This is what you'd like to see actually with a patient. I threw this in here just as not to confuse you, but several years ago we wanted to study the antibody response of animals that have been fed ticks. You can't do that with people. So what animal would you like to choose? Well, my colleague, Dr. Galen Fish, knew I had done a significant amount of work with rabbits, and there was some evidence that you could use rabbits to study some things about Lyme disease. And they have these nice big ears that you can put ticks on them. And sure enough, they made a very good antibody response, as well as we were able to isolate Borrelia from their draining lymph nodes. And just to give you an idea of what type of activity you see in another host that's been exposed to ticks. And there's very nice reactivity to OSP-A and OSP-B and to flagella, as well as a range of about 15 to 20 other proteins. Here are the controls. of these first three lanes are the tick-exposed rabbits. These are pre-sera bleeds of these rabbits, and this is the molecular weight markers and the whole sonicate of Beta-Dorferi. All right, this is a somewhat complicated slide, and I don't want to confuse you. I'm going to point out some of the highlights. Remember, we broke down the patients into three groups. Those who had less than an EM of probably less than 7 days, those between 7 and 14, and those greater than 14. These are the different molecular weight proteins of Beta-Dorferi on this axis here, and these are the percent frequency we see in the patients. And I just want to point out, if you look at IgM, in all the patients, the prominent low molecular weight band is 25, which is near where OST-C is. Not surprisingly, the other prominent band is the flagella, 41 kilodalton, and most prominently with IgG. There's small percentages of recognition of other bands here, and because of time, I really can't go through all of them, but I just wanted to give you an idea of what we saw. And here again, another nice summary of what we saw in the previous slide, broken down into percentages. Not surprisingly, those who have the rash for a short amount of time have only an average of about 2 bands of either M and G. Wait a little longer and it jumps to almost 6 bands, and the greatest number, about 10 bands, with those who had the rash for probably greater than 14 days. This slide is put up here from a paper we published in Journal of Clinical Micro this past December. It's a little complicated table, but the point here I want to show is the PCR data is on this table. And you've already seen some of the serologic data, and that's over here. And I mentioned about some of the culture positive data. And that's all now been put into one table on the evaluable patients. And over here is a bunch of disclaimers related to certain problems that came up during the evaluation of so many patients. But this was the best summary we can get of the available patients we had. And we have here the serology on the initial seropositive was 46%, which isn't unlike what I showed you in the previous slide. Of those 16 patients, 10 of them we were able to isolate Beta-Dorferi, 11 of them were PCR positive. The seroconverters, these are the ones who convert 8 to 20 days later. And we see a jump of 11 from the original 30-plus patients, 38 patients. And of that also, 10 of the 11 were culture positive, 5 were PCR positive. Seronegatives, these are people that never seroconverted. And there were 6 of them. 1 was culture positive, 4 of the 6 were PCR positive. So the percentages are the important points here. You can see how culture positive and PCR positive stack up against each other and how that compares with serology. This is, again, another interesting slide summarizing the data that we have. If we look at the diagnostic value of laboratory tests for Lyme disease, this is a big take-home message. If we just looked at acute serology alone, we can only say we can capture 45% of the erythema migrans population. If we include the equivocals, it's now 55%. If we take acute plus convalescent, it jumps to 81%. If we have just biopsy alone, it's only 61%. We've done some lavages, which is just trying to extract out fluid and not take a punch biopsy, and that's 36%. PCR on the biopsies is 58%. If you add it all up, all modalities of presentation, it's 88%. All modalities, that includes the convalescent serum here, we're up to 91%. So it's not bad. Out of all the erythema migrans cases we got, in this particular study of 33, we could not in the laboratory confirm them as Lyme disease cases in 9% of those we saw. Is acute and convalescent antibody testing helpful, or is it a waste of time and money? This was a slide I borrowed from a friend of mine who tried to tell me that he thought it was a waste of time. And I didn't get a chance to show him the previous data, and I think just the opposite. I think it's not a waste of time. It tells us a lot about Lyme disease, and it tells us a lot about how it may be helpful in diagnosing the patient. Also, it helps people like the CDC or other people who might want sera from different stages of the infection to do things with them. Oh, yes. This is what keeps Lyme, one of the things that keeps Lyme disease going. This is the wild white-footed mouse, Parameciscus leucopus, and it may be difficult for you to see, but there are ticks on its ears. Some of them are actually engorged, and it's believed that this is one of the reservoirs for the Lyme spirochete, and when the ticks feed on them, that's how the ticks acquire them. So I just wanted to put that on there to remind everybody. I don't think we've seen too many mice on our slides here, so what is that? Is that it? I guess, that's another one. These are the ticks, just to give you an idea of what they look like on the palm of someone's hand. Okay, I think I'm going to conclude, but first I'd be remiss if I didn't include the cast of characters that were involved in this, and there have been many. The division chief, Dr. Gary Wernzer, and at least one of the other attending physicians, Dr. Rob Merriman, are some of the physicians who see the patients. My two laboratory technicians, Susan Bitker and Denise Cooper, the people who've done much of the lab work. I'd like to point out the fact, and this is something crucial in lab testing, they have a combined 40 years of laboratory experience. If you combine my laboratory experience, that's almost 60 years. And I think when you do serologic testing, you're really at the mercy of the people in the lab who are doing it. And I wouldn't show this data unless I felt very confident that what I'm showing you is the real McCoy, or things that I believe are actually true data with minimal error. Who else? Oh, our nurses. We have a great bunch of nurses. Two of them in particular, Gilda Forsetter and Diane Holmgren. And they're really, they screen the patients. They help the doctors determine whether these are good candidates to be part of this study. They counsel the patients. There's a lot of work going on here. The patients have to be told what an invasive procedure for culturing the erythema migrans lesion involves. They have to know that they'll have to come back many times, up to 4 or 5 times for follow-up visits. This occurs during the summertime. I wouldn't want to come back for a follow-up visit. I'd rather be out playing softball, baseball, and other things, and having a good time. And people with Lyme disease generally don't have good times. At least that's what we hear. And so they're very important. And I'd probably like to close on that because today is Nurse Recognition Day. Recognize all the nurses today. This is their day. And so that's how I'll end.